Okay, so this is the respiratory system, and we are going to break this up into two lectures, mostly the anatomy in the first part and then the physiology in the next, because it is a little lengthy. So we're going to look at some basic functions of the respiratory system. Gas exchange for oxygen and carbon dioxide. Oxygen becomes absorbed at the alveoli in the lungs, and we eliminate carbon dioxide. We also regulate blood pH here, as we looked at in the carbonic acid cycle, or we will be looking at that. Vocalization, in speaking, and it contains olfactory receptors. So we divide the respiratory system to upper and lower divisions. The nose and the pharynx or throat area is considered the upper respiratory tract, and the lower respiratory tract is essentially anything including the epiglottis and below, the larynx, trachea, bronchi, and lungs. So if we look at this picture here, we can see where the larynx is located. It contains your vocal cords. Above that point is the upper respiratory tract, and everything below is the lower respiratory tract. Okay, so we start with the nose. We're going to follow the pathway of air from the nose, down into the lungs, structure, function, histology, layers that you might see there, just like we did with the blood vessels and with the heart. So the nose, provides an airway for respiration, helps to warm and moisten air, filters and cleanses the air. Again, location of olfactory receptors, and adds voice resonance, or adds resonance to voice. Okay, so let's start at the most beginning portion, I guess you could say. The proximal end of the respiratory system is the entrance point at the nose or the nares or nostrils. So that allows air entry into the external nares or nostrils. And then it leads to the nasal cavity. We have tissue there, pseudostratified ciliated columnar epithelial tissue that has goblet cells within that epithelial layer, and mucus glands deep to it in its submucosa. And that provides a lot of mucus to the surface of the cavity to warm and moisten air, to trap particles. We have hair there for filtration. We have blood vessels there to keep the air, and warm the air. Then we go to the sinuses, and you learn those in the skeletal system. We have maxillary sinuses, frontal, sphenoid, and ethmoidal sinuses. So as a group, we just call them paranasal sinuses now. They function to warm and moisten air as well, trap debris and mucus, voice resonance, and is lined with pseudostratified ciliated columnar epithelial tissue, just like the nasal cavities are. So what you're going to find is that this airway, this air passageway, when air passes through the nasal cavities and the sinus cavities, it adds a lot to voice resonance. And if you've ever been severely congested, or even mildly like I am right now, your voice starts to sound very nasally. So it does change your voice. Any place that's lined with this mucus, which is essentially the entire respiratory pathway that is for air only, then it's going to have very similar functions. Warm and moisten air, try to lubricate, trap debris. What we're trying to do is filter the blood of all kinds of pollen and dust particles before it gets down to the alveoli of the lungs, where we're going to gas exchange. So don't be surprised if there are somewhat similar functions, structure to structure. All right, then we get into the throat area. We have three regions: the nasopharynx, oropharynx, and laryngopharynx. So to the posterior aspect of the nasal cavity, above we call the uvula, that's that little kind of triangular piece of tissue that hangs inferiorly from the back of the roof of your mouth, posterior aspect of the roof of your mouth. So above the tongue, between the nasal cavity and the throat, we have the nasopharynx. That is also where we find the opening of the eustachian tube, or the pharyngotympanic tube. that connects the upper part of the throat to the middle ear behind the tympanic membrane. That's the tube. When your ears pop, you're trying to equilibrate air pressure on both sides of your tympanic membrane. And that's where the opening of that eustachian tube is in the upper part, that nasopharynx area. Then we have the oropharynx, which is level with the tongue. And below that, to the point where we enter the larynx, is the laryngopharynx. Now, in both of those regions, food and air is capable of passing through there. So when you also have food passing through a chamber, it's not going to be lined by this pseudostratified columnar epithelium, right? It's going to be lined with stratified squamous epithelium, because food is very rough and very textured. Right? So where we have air only, primarily in this system, will be lined by what we call PSCET, PSCCET, pseudostratified ciliated columnar epithelium. But where you have food primarily passing, it's going to be lined with stratified squamous epithelium. All right, so here we can see kind of one of those half head models that we use in lab. We have the entrance point of air, in the nose or in the nostrils and nares to the right hand side about 3 o'clock. You have your nasal cavity. To the back portion there, we have the nasopharynx. Right, then we have oropharynx level with the tongue, and laryngopharynx below that, and then you enter into the larynx itself. And so the larynx is essentially a structure of 3 different cartilages that enclose and hold your vocal cords and your vocal folds. Okay? We have the thyroid cartilage, which when you're looking from the anterior to posterior, right to the front of an individual, it's the broadest part there, the thyroid cartilage, and it contains the vocal cords. Superior to that is your epiglottis. That's the elastic cartilage flap that regulates the passage of air into the larynx and closes that off, that entrance point, when you're trying to swallow food, so that food goes down the epiglottis, into the esophagus. We have 2 other cartilages, the arytenoid and cricoid cartilages, that support the vocal folds. The arytenoid cartilages are the only paired cartilage. We'll look at those. They kind of look like, I don't know, horns, actually. There are 2 of them. And then the cricoid cartilage, is narrow anteriorly. It'll be seen or visualized inferior to the thyroid cartilage. And when you're looking at the backside, the posterior looking anterior, then it's going to be this broad portion. As a group of functions for the larynx, it acts as a switching mechanism to separate food and air, so that air goes into the larynx and food into the esophagus, voice production, and it provides a patent airway to follow. Here we're looking anteriorly. We have the hyoid bone to the top. Then we have the thyroid cartilage, which is the broadest part when we're looking right at you, right? Or you're looking at someone, face on. That's what we refer to as the Adam's apple, that little prominence there. And then below that is the cricoid cartilage, which is narrow, in the front part. When we look at from the backside of we're going to take a sagittal cut and look at it. It's rather broad in the back. And then we have the trachea, which is composed of these tracheal cartilage rings. And if we look at that sagittal view, we can see the vocal folds, and we can see the arytenoid cartilage. See, it kind of looks like a horn. They would be 1 on each side. They place tension on the vocal cords to change the pitch of your voice. So anterior aspect is over to the right. You can see the hyoid bone and the thick part of the thyroid cartilage. And to the back, do you see how broad that cricoid cartilage is? So just don't confuse your thyroid cartilage with your cricoid cartilage, that's all. And then we can see these cartilage rings in the trachea. So the trachea, we have 4 layers of tissue and different tissues found in each that provide different functions, of course. And it's similar to layers of a blood vessel, layers to the heart, where you have, tissues that perform a specific function. So the trachea, in this slide, we generally look at an AMP1, when it comes to the skeletal system, and we looked at the hyaline cartilage, elastic, and fibrocartilage histological slides. This is generally location of the hyaline cartilage that we look at because it's a really good location to see abundant hyaline cartilage. Okay, so the first layer that's closest to the lumen is called the mucosa. It's composed of pseudostratified ciliated columnar epithelial tissue. The cilia directs mucus away from the lungs, and the goblet cells produce mucus onto the surface. But deep to this layer, we also have mucus glands that will also express mucus to the surface. These cilia are designed to be upward in a singular direction, so that as the mucus traps dust and particles and so forth, that it doesn't become overweighted and kind of sink down into your lungs, that we beat upward so that it's mobilized to either an area of the pharynx where you can cough it up or spit it up, and more likely it actually will just be brought up through the larynx as far as it can to be swallowed. Essentially, it'll move into the esophagus. Okay, the submucosa contains areolar connective tissue for support and simple cuboidal epithelial tissue that forms the mucus glands, and that mucus traps debris. Next, we have the hyaline cartilage rings. Right? The next layer is the hyaline cartilage, and it's composed of the tissue hyaline cartilage, and that maintains a patent airway. You don't want your airway, this hose, so to speak, to collapse on itself. In the same respect, you don't want hyaline cartilage around the entire circumference, 360 degrees around the pipe either. You want it to be open and flexible in the back where you have the esophagus behind it or posteriorly trying to transport food. So there'll be a flexible area on the back side or the posterior aspect of the trachea, and the other regions or the remainder, about 80%, 70% around the trachea will be the hyaline cartilage so it doesn't collapse on itself. And then between each layer of or ring of hyaline cartilage is going to be some flexible connective tissue and some muscle, especially in the posterior aspect. And that allows your trachea to be a little flexible. You don't want a solid pipe. You want a flexible pipe. So when you laterally flex your neck, rotate your neck, forward flex, extend your head back, is that pipe will move without collapsing. And so it'll be flexible without being compressed. And then the outer connective tissue layer is called the adventitia layer. It's composed of areolar connective tissue. Like any outer connective tissue layer of any organ, it helps to support it and affix it into its location. It helps secure blood vessels and nerves to the structure. We call it adventitia when it's in the thoracic cavity. Once we have organs that are outside the thoracic cavity, in the abdominal pelvic cavity, that outer connective tissue there is called serosa. Right, so the function of the trachea is pathway of air conduction from the larynx into the thoracic cavity, not into the lungs, but into the thoracic cavity. All right, so here in the upper left-hand side, they're showing you where they're going to take a section and magnify it. And so here we can see the lumen of the trachea. The first layer would be the mucosa, composed of pseudostratified ciliated columnar epithelial tissue. Then we have the submucosa, areolar connective tissue, and simple cuboidal epithelial tissue. Then we can see the hyaline cartilage layer, composed of hyaline cartilage, the light blue soap bubble material. And then the adventitia to the outside. Those are the layers composed of areolar connective tissue. So you should be able to identify the layer, the tissue found there, and the functions of those tissues. To see how the hyaline cartilage does not make it a complete circle, it's kind of open in the back with flexible connective tissue and some muscle tissue that allows some expansion of the esophagus behind it, kind of into the trachea a little bit. So there's some flexibility. And here we're looking at a slide. It shows you the mucosa, submucosa, and hyaline cartilage layers. The serosa, the adventitia would be to the lower right-hand side if we could have had room for it all. But now you can see the tissue and then no functions of the tissues in each layer. All right, the bronchi. Now we're entering the lungs. So at the inferior aspect of the trachea, we have the carina, and the carina is the point where that trachea bifurcates into a right and left primary bronchi that transports now air into the right and left lungs. So it's going to divide multiple times, just like a large artery branches off into smaller and smaller arteries before it becomes an arteriole. The bronchi do the same thing, and for all intents and purposes has the same histological makeup as the trachea. The only difference is it's not going to have the same kind of outer connective tissue, and the submucosa is minimal. It's got a little bit of material in there. Okay, so it will be lined with the mucosa, pseudostratified ciliated columnar epithelial tissue. It's going to have a hyaline cartilage layer, and that's how you're going to distinguish it from a bronchiole, because it can vary in diameter before it becomes a bronchiole, where you'll have smooth muscle. All right, so here we can see the trachea at the point where it bifurcates. It's called the carina. You have main bronchi entering into each lung. Note while we're here is that the right lung has 3 lobes. The left lung only has 2 lobes. And remember, that's because it has to accommodate the heart on the left side. Right, then we branch into bronchioles, and they are smaller diameter, still tube system for transporting air, but it has 2 major differences histologically. The mucosa changes to simple cuboidal epithelial tissue, and rather than having hyaline cartilage, it has smooth muscle. Therefore, it is under the control of the autonomic nervous system to bronchoconstrict and bronchodilate. Right, so I would know and review autonomic nervous system. What is the response of the parasympathetic division of the bronchioles? What is the response of the sympathetic division of the bronchioles? This lets you see exactly, or a very good picture of how the alveoli merges with an alveolus. So the alveolus is like a capillary. It's one single layer of simple squamous epithelium. And like an arteriole that leads to a capillary, we have the bronchiole, capable of bronchoconstriction dilation, terminating on the alveoli. So they almost look like little grapes, grapes on a little cluster. The alveoli is your site of gas exchange. It's a single layer simple squamous epithelium fused to a basement layer of capillary. And we'll talk about that because that is the respiratory membrane. Right? This forms the respiratory membrane where gas exchange by simple diffusion occurs. Right? The alveoli is composed of 2 major types of cells, type 1 cells that form the walls of the alveoli, and type 2 cells that secrete surfactant. Surfactant is a fluid that helps prevent the alveoli from collapsing when you exhale. If you don't kind of maintain a patent alveoli, it's going to collapse and just compress. So picture blowing up a little balloon. You blow it up, you squeeze off the end so the air is maintained in the balloon. But if you release your hand, the air starts to escape from the balloon. And if you let all the air escape, what happens? The walls of the balloon collapse on themselves. Well, you don't want that to happen in your lungs because it's very difficult to re-inflate them again. So this surfactant, this compound, helps resist that temptation by interfering with the surface tension of water. You may also find, and you do, some macrophages at that level in the event that some bacteria or dust travel that far down into the alveoli. And right from there, you can initiate an immune response also. Okay, so in this picture is showing, to the left where this image is originating from, and let's blow that up. So look at the bronchioles. They actually look like arterioles. Remember the arterioles had little rings of smooth muscle surrounding them for vasoconstriction and dilation. Well, this will facilitate bronchoconstriction and dilation. And then we can see the alveoli. Right? They kind of look like a bunch of grapes on a stalk of grapes. and we can see these elastic fibers or elastin fibers that surround them. That's going to be very, very helpful and instrumental with trying to exhale. Because when you take air in, we're going to pull apart the lungs, which creates a negative pressure inside, and you suck in air. But when you go to exhale, you need to compress down on the lungs to force air out, this whole airway, air pathway. And to facilitate that, the elastic fibers will stretch when you inhale and recoil back again when you exhale to try to compress, as much as it can, those alveoli in these regions to expel as much air as possible without collapsing or compressing the alveoli. So they stretch back again, like a rubber band would. Right here we can see a slide. If you can see alveoli, which is the kind of looks like adipose connective tissue, but it has that chicken wire, honeycomb kind of an appearance. When you see that kind of tissue, you're in the lungs. So if you're in the lungs, you are not looking at a trachea. You are either looking at a bronchi, a bronchiole, or the alveoli. Right? And we're going to show you how to tell the difference between a bronchi and bronchiole. But once you see that tissue there that looks like a honeycomb kind of material, you know that you're in the lungs. And if you can further magnify them, you'll see that the walls of those honeycombs are composed of multiple dark staining nuclei, and those are strings, or a layer of simple squamous epithelium. The difference between a bronchiole and a bronchi, if you see hyaline cartilage in part of the circumference of the tube you're looking at on end, in the lungs, if you can see some hyaline cartilage there, some light lavender, light blue, soap bubbly material, it's a bronchi. If you don't see that, and perhaps you can even see some smooth muscle, then you're looking at the bronchiole. Right here, we're looking at the blood supply and the capillary supply around the alveoli. So remember that the blue vessels are the arteries and the red are the veins because we're in the lungs. So blood is transported through the blue side, tapers off into a capillary bed, just like it does in systemic circulation, and leaves as veins in the red vessels. And so the respiratory membrane that we're going to talk about is the simple squamous epithelium of the alveoli, sandwiched with the simple squamous epithelium of capillary. And then between the two is a little bit of what we call basement membrane. So here we have, to the left-hand side, one big alveoli or alveolus. We can see the blood supply surrounding it. We can see a couple of macrophages here and there, single layer of epithelial tissue. Over to the right, they're saying, okay, if I magnify the layer of that, what they have tan cells here as the alveoli, the simple squamous there, and we also look at the simple squamous of the capillary, that is your respiratory membrane. And so in red here, the respiratory membrane is essentially the simple squamous of the alveoli, some basement membrane, and then the simple squamous layer of your capillary. The thinner that is, the easier the gases diffuse, and the more rapidly. Oxygen moves from inside the alveoli down its concentration gradient into the bloodstream. And then the carbon dioxide, which is high concentration in the blood, will diffuse into the alveoli. Again, passively diffusing down their concentration gradients. And then you exhale and you eliminate the carbon dioxide, or most of it. Respiratory membrane is very, very important. This is where, when you have pathologies there, it severely interferes with your ability to diffuse gases appropriately. So here we're just, I tried to kind of synopsize the changes of tissues, things that are common and not common, along the pathway of your respiratory system. Frequently looking at the epithelium, but when necessary, especially when it comes to the bronchi and the bronchioles, the bronchi are like a trachea with hyaline cartilage, but bronchioles have smooth muscle for bronchoconstriction and dilation. All right, so changes in the respiratory tree. Tracheal hyaline cartilage rings replace smooth muscle in the bronchioles, as I just mentioned, so keep that in mind. The epithelium gradually changes. Where you have air only, in the nose, sinuses, and nasal pharynx, we are lined with that PSCCET, pseudostratified ciliated columnar epithelial tissue. When we enter into the oropharynx, laryngopharynx, which is a common pathway for food and air, it's lined with stratified squamous epithelium. Then as the air enters into the trachea and the bronchi, we reline with pseudostratified ciliated columnar epithelial tissue. Remember, these are just epithelial changes. Then the bronchioles become lined with simple cuboidal, and the alveoli are composed of simple squamous epithelium. Remember, smooth muscle found in the bronchioles can be affected and is affected by the autonomic nervous system, sympathetic and parasympathetic divisions. By releasing epinephrine and norepinephrine, we are capable of bronchodilation and reversely bronchoconstriction, or conversely, I guess I should say. Okay, the lungs. Each lung is lined with its pleural membranes. We have the parietal pleura, which is intimate with the wall of the pleural cavity that will eventually attach to the lungs via the visceral pleural, because the visceral pleura is attaching to the lung tissue itself. So you have these two layers of tissue with serous fluid in between to reduce friction. Remember, these membranes are interconnected to one another. So as the ribs elevate, and we talk about the process of inhalation, when the ribs elevate up and out, it pulls its parietal pleura, which is attached to the visceral pleura, which is attached to the lung, and pulls the lungs in the same direction, up and out. This pleura also attaches to the diaphragm, so as the diaphragm moves, it pulls on the lungs as well. Right, so this is just a transverse section of seeing where the lungs are located. You can see the parietal and visceral pleura, and where the ribs go, the pleura go, and with the diaphragm also, when they move, it pulls the lung tissue with it. Okay, the respiration processes. Normal respiratory rates are 12 to 20 respirations per minute. Magic number, 12 to 20. Pulmonary ventilation is the movement of air into and out of the lungs. We have two places of gas exchange. We have external respiration and internal respiration. External respiration is the gas exchange that occurs at the lungs itself, between the gases in the alveoli and the gases in the blood passing through the lungs. That's called your external respiration. Internal respiration is what occurs at the capillary level as we transport blood in systemic circulation, going out to the capillary beds deep in your tissues. Think of your muscles and joints. We have cellular respiration, which is how we use oxygen in each individual cell, how the mitochondria is going to use glucose and other substrates with oxygen to form ATP. And as a product of doing that, we produce carbon dioxide. That's where the carbon dioxide comes from that we need to exhale away. And transportation of respiratory gases is the function of the cardiovascular system. Right, so the processes include pulmonary ventilation, air in and out, the exchange of external respiration, internal respiration, and dependent on the circulatory system to transport them. So in external respiration, we have pulmonary gas exchange. Right? Oxygen is higher concentration, and that's why we have CO2 in alveoli is greater than, right? That's what that symbol means, greater than the oxygen levels in blood. So now you see your diffusional pathway. Oxygen will move passively from inside the alveoli to the blood. In reverse, carbon dioxide moves the opposite direction. It's in high concentration in the arterial blood. Remember, the arteries are still blue because they're high in carbon dioxide. Right? So the concentration of carbon dioxide in the blood in the capillaries is greater than that in the alveoli. So now we have a diffusional pathway for carbon dioxide from the blood into the alveoli. And now you can exhale it. Internal respiration is the exchange at the tissue levels, important in systemic circulation. Right, so it is opposite to what just happened in the lungs. Now, as we enter the capillary or arterial blood enters the capillary bed, oxygen is high concentration in the blood and low in the tissues because the tissues and cells are using that oxygen in their mitochondria to form ATP. So oxygen will passively diffuse from the blood into those interstitial spaces and into the cells. And reverse for carbon dioxide. Carbon dioxide is now high in the cells. It will diffuse into the interstitial spaces and into the capillaries, into the blood. So it can be transported to the right side of the heart, to the lungs, to be diffused again into the alveoli and exhaled away. The ventilation process includes cycles of inhalation and exhalation. To inhale, the diaphragm contracts and moves inferiorly, pulling on its serous membranes and pulling down on the lungs. Right, the external intercostal muscles contract and they pull the ribs up and out, as well as X on the sternum. You know, when you take a breath in, just kind of palpate your sternum, and you'll see it moves anteriorly. If you were laying flat on your back, I'd say it rises. And because the diaphragm contracts and depresses or moves inferiorly, that is why your stomach rises, because it displaces some of those organs in the abdominal pelvic cavity. So where the diaphragm and the ribs go, they pull on their serous membranes, they pull on the lungs. It creates a negative pressure inside, and you take in air. Exhalation, the opposites will happen. Right? The rib muscles, the intercostal muscles relax, and the ribs drop down immediately to compress the lungs. The diaphragm relaxes and elevates. And now we kind of squish down laterally on the lungs and push up from the bottom. You know, so that the pressure becomes very high in the lungs and it pushes air out. Remember that we also have elastin fibers surrounding these alveoli, and they really help with a kind of compressing back each alveoli so that it doesn't, you know, the surfactant keeps it from collapsing, but that we move gases not just on the peripheral and inferior surface, but throughout all the lung tissue. So it depends, you know, exhalation depends on the elasticity of the lungs. If elastic tissue is damaged, lungs cannot recoil back to the normal size. So you'll have, you know, gas movement or air movement to a certain extent, but not, you know, as much as you would hope for or you need to. Okay, so this you can read through these. These are just images that talk about what I just mentioned before. You know, I think it's good to see have a visual picture of where these are moving upon inhalation, especially the diaphragm, because you know, you picture the diaphragm for whatever reason, I think moving superiorly instead of contracting and moving downward. Right, so this just illustrates the same mechanisms I just mentioned, inhalation and exhalation. Ventilation depends on the pressure gradients also between atmospheric air and the alveoli. You know, ventilation is produced from pressure volume changes in the thoracic cavity during inspiration and exhalation. So what do they mean by that? It just means that when you go to inhale, when you inhale and the ribs move and the diaphragm, the ribs move up and out and the diaphragm moves inferiorly, it creates a negative pressure in there. Right, so that causes you essentially to suck in air, which is inhalation. When we go to exhale, then the ribs move downward, the diaphragm moves upward, and we really compress and increase the pressure in that pulmonary, in that thoracic cavity in the lungs. And now by increasing the pressure, we compress the lungs and decrease the volume of material that's in. So there's a relationship between pressure and volume. Right? And that takes us to Boyles Law. And it says at a constant temperature, the pressure of a gas varies inversely with its volume. So just try to picture it this way. If P1 V1, which is your starting pressure and volume, equals what you end with, P2 V2, because that's what that means. All right. So let's just look at P1 V1. All this means is that if pressure goes up, the volume must go down. Right. If one goes up, the other goes down. Otherwise, you know, you won't be equal to the equivalent on the other side, the P2 V2. And the same for P2, V2. If P1, V1 stays the same, and the pressure goes up, P2 increases, then V2 has to decrease. All right, so as pressure goes up, volume goes down. If pressure goes down, volume goes up. That's Boyles' law. Right, factors that affect ventilation is similar to the factors that affect, like we were talking about blood flow through blood vessels. It's along those same lines. You want to facilitate maximum amount of air entering and exiting this system, and changes can occur anywhere from the nostrils, all the way down to the alveoli. So things that could affect it is the resistance, along the passageways. If we increase resistance, we decrease airflow. Just like in the blood vessels, if we increase resistance, we decrease blood flow. It's the same thing. And things that can increase resistance are things like too much bronchoconstriction, changing the diameter of a tube, having too much mucus being secreted on the surface, like an anaphylactic shock, or anaphylaxis, I should say, not anaphylactic shock, but anaphylaxis, where you are producing a lot extraordinary mucus that is narrowing the diameter of the passageway of the trachea and the bronchi, or even the bronchioles. Right. So if you make a tube smaller in diameter, it creates resistance, so less air gets in and out. Lung compliance is ease of that lung to expand or stretch. So, how about those elastic fibers to be able to stretch? That the lungs, the ribs can move adequately, that the diaphragm can contract inferiorly. The elasticity of the lungs is the ability to recoil. So we've said before that the elastic fibers are a crucial part of being able to exhale. So if you can't, if you can't stretch them, then you can't have them recoil again. And if you don't have good quality elastin fibers and multiple walls of alveoli, then you are not going to get this recoil, effect that allows you to eliminate as much carbon dioxide as possible. This is severely inhibited with emphysema. It's one of the COPDs. Okay, and then alveolar surface tension forces. Well, this is the presence or lack thereof of surfactant. You need to have surfactant in those alveoli to keep those alveoli from collapsing and compressing. Okay, then we have diffusion through the respiratory membrane. The respiratory membrane is normally thin and gas exchange is rapid. These factors enhance diffusion. So we're going to look at things that help diffusion and expedite it. And of course, the reverse would inhibit diffusion, and cause carbon dioxide to back up, and not be fully oxygenated in our blood. So things that enhance it is increased diffusion is favored with increased surface area. The more nice plump alveoli you have, those little grapes for diffusion with nice capillary beds surrounding it, the more diffusion will occur. The shorter the distance, between the layers of the alveoli and the blood vessel, meaning the thickness of that respiratory membrane. We want it super duper thin, like two very thin pieces of paper next to each other. The shorter the distance, the faster the diffusion. The thicker that layer is, the less diffusion will occur. Because blood passes very rapidly. The blood only circulates through the lungs and the capillaries, about 0.775 seconds. Less than a whole second does it enter the lungs and it's right back out again. So you have to have the maximum amount of diffusion occurring. The greater the solubility or the concentration gradients, meaning the more steep the pressure gradient is, the more the difference between, let's say, oxygen inside the alveoli and that of the lungs, and that of the capillary blood, the bigger the difference that is in concentration, the faster oxygen moves into the blood. And carbon dioxide, carbon dioxide is high in the blood, entering the lungs, and low in the alveoli. So the higher it is in blood, the faster, and the lower it is in the alveoli, of course, then the steeper the concentration gradient, the faster you have diffusion. And then we have what's called ventilation perfusion coupling. It's the matching of alveolar ventilation with pulmonary perfusion so that blood flow is reaching the alveoli. Right. So what this means is that when you shallow breathe, you're not inflating all areas of your lungs, and their alveoli maximally. You're just inflating, more local regions, let's say. So even though you feel your chest elevate and depress and your stomach elevate, is compare shallow breathing movement to taking in a big, breath of air. Well, if we're not going to expand maximally those alveoli, then we don't need to bronchodilate there. And if we're not going to bronchodilate there and have a lot of air pass through there, then we don't need to vasoconstrict to that area either. So what we have a tendency to do is bronchodilate and vasodilate to the areas that will get the most air, and not necessarily constrict, but to a certain extent, bronchoconstrict and vasoconstrict to the areas that are not going to be fully expanded and have lots of air being exchanged through there. Now, when you take a big breath of air and expand your lungs as far as you can, or if you're exercising, then yes, we are going to bronchodilate and vasodilate to all those regions that have lots of gas into and out of those regions. But when you're shallow breathing, we kind of save energy, and circulate blood to the areas where there's going to be the most gas exchange occurring. So and then it says on the bottom, conversely, decreased diffusion occurs from decreased surface area. A thicker or increased distance, between, or thickness of the respiratory membrane, or distance between the alveolar wall and the blood vessels. When we don't have a steep concentration gradient, then we're not going to have, so diffusion will decrease. So keep that in mind. But especially for quiz questions, test questions, know these 4 variables. In the same respect, you should know the variables associated with ventilation, with airflow out of the system, and then diffusion across the respiratory membrane. Our clinical homeostatic imbalance is emphysema, and then some other pathologies that can affect this, but certain pulmonary diseases drastically reduce the alveolar surface area. So that's why, if you understand what these variables or these different, how they affect diffusion or maybe airflow, then you start to picture what you would expect to happen or how you might address correcting certain things when you have these different pathologies. So then you have to understand, okay, well, what's physiopathology of emphysema? Well, when you have emphysema, instead of having, let's say, a bronchiole with 10 alveoli terminating on it, like 10 grapes on one little stalk of grapes, it maybe has 3 large ones. And that cuts down on the surface area. 10 individual walls of an alveoli have a lot more surface area than 3 big ones. Right? And therefore, the less alveolar surface area we have with capillaries next to it, the less diffusion of gases occur. So that carbon dioxide has a tendency to build up in the blood, and you don't fully oxygenate either. And so what happens when carbon dioxide builds up in blood? It, carbonic acid cycle, right? It interacts with water to produce carbonic acid, which liberates hydrogen ions, increases the hydrogen ion concentration, decreases the pH, and now we have acidosis. Other things that can affect that are tumors, extraordinary mucus, and inflammatory material at that level. It can also reduce the surface area by blocking gas flow into the alveoli, or actually the alveoli themselves. So factors or any pathology that affects the surface area here, the distance, the thickness of the respiratory membrane, let's say with pulmonary effusion, or edema, that changes the concentration gradients. Up in here, anything that increases the resistance, decreases the compliance, the ability of the lungs to stretch, the elasticity, the amount of surfactant. Now you see how it can affect, airflow. Maybe the alveoli, are just fine, but it's just the tube system is too narrow. Or we have issues, right at the respiratory membrane. Diffusion through the respiratory membrane. These all affect the respiratory membrane. Okay. Another homeostatic imbalance is what I just mentioned earlier. The effective thickness of the respiratory membrane increases dramatically if the lungs become waterlogged or edematous. We've seen in pulmonary edema or left heart failure, pneumonia, pulmonary edema, or left heart failure. So what happens if the left ventricle does not contract? The blood backs up, and that's why you have to know the direction of blood flow through the heart. If the left ventricle does not push blood into the aorta and into systemic circulation, it backs up to the left atrium, which backs up into the pulmonary veins, which backs up back to the lungs. And the same thing can happen at the lung capillary level as it does in peripheral circulation. If things aren't moving forward, the blood is residing in the capillaries too long. And remember, entering and exiting the capillary, you have hydrostatic pressure going in and osmotic pressure kind of pulling fluid kind of back into that capillary. Well, if if you're only losing fluid at the capillary bed because there's a blockage, on the venous side of the capillary into the veins, to the left atrium, to the left ventricle, then the fluid accumulates there. And that's what can happen with left heart failure. The 0.7 seconds that red blood cells spend in transit through pulmonary capillaries may not be enough for adequate gas exchange. The result is body tissues suffer from oxygen deprivation, but even worse is the buildup of carbon dioxide and not eliminating carbon dioxide. Okay. The amount of oxygen released from oxyhemoglobin increases with, and let me explain this to you. Great. Hemoglobin, of course, you've learned this in the first chapter of blood, are two quaternary structures of proteins with a hemi group in the center with an iron molecule that binds to oxygen. Without any oxygen bound to it, the molecule is called hemoglobin. When oxygen binds to it, it's called oxyhemoglobin, or think about oxygenated hemoglobin. And when carbon dioxide binds to it, it's called carbaminohemoglobin. I know it's a mouthful. Okay, so there are certain factors in environments that stimulate hemoglobin to readily release oxygen in environments which will make sense, where you want to drop it off, and where you're going to pick up carbon dioxide. And I will tell you that hemoglobin would rather bind to carbon dioxide than oxygen. And once we again look at the carbonic acid cycle, is that this will make sense because carbon dioxide is essentially a toxin, a waste product and a toxin that can cause your pH level to drop. And when it drops, it denatures proteins, right? It changes hydrogen bonds. So we really need to get rid of that carbon dioxide, and that becomes kind of paramount. We can survive on less oxygen, not zero oxygen, but less oxygen. Okay. So what are things that stimulate the dissociation of oxygen to hemoglobin? The concentration gradients of these things. Concentration of oxygen and carbon dioxide. Hemoglobin has a higher affinity and binding preference with carbon dioxide than oxygen. So in areas, you can hear my dogs barking here. In areas where the carbon dioxide levels are high, like in systemic circulation, at the capillaries where the tissues are working hard, and where carbon dioxide diffuses from the tissues and the cells into the blood, it's moving down its concentration gradient. And so it has a tendency to kick the oxygen off the hemoglobin so that it can, be taken up into red blood cells and be transported back to the lungs, but it also, boom, you drop off the oxygen. So oxygen wants to diffuse anyway, but it helps it happen faster. Let's put it that way. Okay, the blood pH. The lower the blood pH, the faster and more rapidly oxygen dissociates from the hemoglobin. And with the higher temperatures facilitate that as well. Increase oxygen detachment from oxyhemoglobin. And let me just kind of explain that to you, because this will make sense. Picture working skeletal muscle, right? You're converting a lot of glucose using oxygen to produce ATP, and you're also producing a lot of carbon dioxide. So the muscles are working, right? So you're increasing carbon dioxide, you're increasing your hydrogen ion concentration, and you're decreasing your pH, all right? So the blood pH is dropping and the temperature is rising because think of it, you're also producing heat when muscle contracts. So when you have environments where you have especially a lot of activity, because that's stimulating the production of carbon dioxide, think of the impact it has on pH. It decreases it. And both of those things stimulate the detachment of oxygen from hemoglobin. It's called the Bohr effect. And then we have, hold on, my dog is eating something. Hey, Max, let's not eat that, please. Can you call her out of here, please? Because I'm trying to zoom this. All right, Maggie, go. The pit bull here. All right, she eats all your mail. Okay, and lastly, one of the factors is the level of 2,3-diphosphoglycerate or biphosphoglycerate. Right, this is a molecule that builds up in the red blood cells, with activity, and that molecule has a tendency to modify and kind of change, kind of twist. Let's think of it that way. The hemoglobin a little bit, so that it releases the oxygen and enhances detachment. All right, so though in elevated levels of that molecule kind of changes the shape of your hemoglobin, so it quickly releases the oxygen. So the Bohr effect, oxygen binding affinity to hemoglobin is inverse related to both acidity and the concentration of carbon dioxide. Thus, when metabolic activity is high, O2 will dissociate from hemoglobin and supply the cells. All right, so all they're saying is that, as certain levels of things go up, we are going to release more oxygen. And this is an oxygen saturation curve, that shows you in the dark black line in the center, what the normal relationship is. The saturation of oxyhemoglobin or oxygen saturation of hemoglobin is on the vertical axis, and the partial pressure or concentration of oxygen is on the X or horizontal axis. And the black solid line in the center shows you the normal relationship between saturation and the partial pressure of oxygen. Given a certain partial pressure, like at 40, you will have, almost a 70% saturation rate. So what they often refer to are right and left shifts of this line, and they'll do this in nursing also. So look at the top, it says left shift. When we have a decrease in temperature, decrease in 2,3-diphosphoglycerate, a decrease in hydrogen ions, and ultimately a decrease, of carbon dioxide, is that causes oxygen to stay essentially saturated to hemoglobin longer. If you have decreased activity, like in decreased temperature, and you're not producing a lot of carbon dioxide, nor are you producing, a lot of hydrogen ions, then you don't need to be letting go of all that oxygen. We're just going to leave it bound to hemoglobin to use maybe later. The reverse happens when you have higher levels of activity indicated to the right. So it says you have a right shift of that when we have an increase in temperature, increase in diphosphoglycerate, increased hydrogen ions, increased carbon dioxide levels. Now it will, stimulate the dissociation and the release of oxygen from the hemoglobin. That's what they just refer to as left shift, right shifts. Carbon dioxide transport, blood flow into the capillaries gains carbon dioxide because the tissues have a high concentration of carbon dioxide, because that's the job of cells. The cells need to be able to have ATP for different pumps and activities, and it does so by converting substrates into ATP in the mitochondria, which is the source of carbon dioxide. Carbon dioxide is transported to the lungs in one of three forms. The least amount is transported as dissolved, just carbon dioxide free gas in plasma, only about 7%. When it's bound to hemoglobin, it's called carbaminohemoglobin, and that's about a quarter, like 23%, of all carbon dioxide. But the majority is transported as a bicarbonate ion, about 70%. About 70%. And that takes us to the carbonic acid cycle. Right. So this is this equation I've been referring to. Right. Carbon dioxide plus water produces carbonic acid, which then liberates hydrogen ions, which affects pH and a bicarbonate ion. Right. So the carbon dioxide normal levels are 35 to 45 millimeters of mercury. Water is abundant in the body. So when the carbon dioxide level goes higher than normal or lower than normal, it ultimately affects the amount of carbonic acid and the hydrogen ions, and thus it impacts the pH of blood. If we produce more carbon dioxide, then we produce more hydrogen ions, which decreases the pH. And if we produce less carbon dioxide, or there's a lower amount of decreased amount of carbon dioxide in blood, maybe less than 35 millimeters of mercury, then the hydrogen ion concentration decreases and the pH starts to go higher than what we want. And then as far as the transportation of carbon dioxide, when we look at this equation, carbon dioxide essentially is then captured in that bicarbonate ion. But it made a big alteration to the pH along the way. Right, so occurs this equation, occurs primarily in red blood cells because we have a lot of what's called carbonic anhydrase, which is an enzyme that speeds up this reaction in reversible directions. It can either go from the left to the right or the right to the left, thus the arrows in two different directions. In systemic capillaries, after bicarbonate is created, it quickly diffuses from the red blood cells in the plasma. So when this is occurring in the red blood cells, when the bicarbonate is reaching certain levels and starts to increase, it's going to diffuse from inside the red blood cell out into the plasma. But to do so, it needs to have a chloride ion that also has a negative charge swap places with it into the red blood cell. And that's what we call the chloride shift. If bicarbonate is increasing in the red blood cell, it will diffuse out and chloride will enter. And vice versa. If bicarbonate levels are decreasing in the cell, then bicarbonate will diffuse from the plasma into the red blood cell, and chloride will go from the red blood cell out into the plasma. They just switch, directions. They kind of are anti-transporters, so to speak. They go in opposite directions. Okay, respiration control. It's primarily controlled by the medulla oblongata. We have neural mechanisms, and then we have influence from higher brain centers, but the neural mechanism, is primarily the function of the medulla oblongata, because it generates and modifies your respiratory rate. Injury to the medulla oblongata is going to severely impact respiration. The pons also helps the medulla oblongata by smooths your respiratory rhythm. And then we have other areas that can affect respiratory rates. We have the hypothalamus, which activates your sympathetic and parasympathetic, your autonomic nervous system. The cerebral cortex, you can change respiratory rates depending on the, maybe the emotional things that are going on, emotional stimulation, fear, being crying, being emotionally upset. Chemoreceptors found both central and peripherally. Remember, you have peripheral chemoreceptors with those baroreceptors in the carotid arteries and the aorta. But we also have central chemoreceptors too throughout the brainstem. So when those are responding to varying levels of, depending on what they are specifically chemically responding to, is maybe carbon dioxide or oxygen levels or pH and those hydrogen ions. The impact or the stimuli, the signals from those particular chemoreceptors may stimulate the medulla oblongata to either increase or decrease respiratory rates. So CO2 is the most potent and mostly controlled of these. And that's because, as I described before, and in the carbonic acid cycle, is that it's a waste product. It has a big impact on the pH of blood because it forms hydrogen ions. So with an increase of carbon dioxide in blood, right, because it produces an increase in hydrogen ions, we are going to respond by hyperventilating. So if we are holding our breath, let's say, and the carbon dioxide is building up, what happens when you go to breathe normally again? You start to, kind of pant, or not pant, but you increase the rate and depth of your breathing. And so you can blow off the carbon dioxide because we eliminate carbon dioxide in exhalation and take in more oxygen in inhalation. Right. So if the carbon dioxide level is high in blood, we are going to try to hyperventilate and blow it off. In contrast, if it's decreased in the blood, then we are going to hypoventilate. Ways that we decrease the carbon dioxide is by hyperventilating, and during fear or a panic attack, or, kids will often do that. You'll see children when they're about to cry and they'll start hyperventilating, when and they're wailing. So hyperventilating, blowing off too much carbon dioxide, will then trigger you to want to essentially hold your breath or decrease the rate of ventilation to the lungs so that the carbon dioxide builds back up to a normal range. So remember, keep in mind, I guess you say, that the normal range is 35 to 45 millimeters of mercury. Right? If it goes above 45, then our response is to hyperventilate. If it goes below 35 millimeters of mercury, and lower than normal, then your response would be to hypoventilate to bring the carbon dioxide levels back up. That's why we have normal, quote unquote, levels, 35 to 45 millimeters of mercury. Okay, just as a review, don't forget which cranial nerve conveys sensory information from the carotid bodies. That's glossopharyngeal, cranial nerve 9. And from the aortic arch is vagus nerve 10. All right, this is an FYI. I was going to take a break through this, but I guess this is kind of rolling. So I'm just going to finish this up. I don't ask you questions in the future. I probably will, but depending on where you take lab, they may ask you these questions. And so I'm going to define these things and give you a little bit of heads up of probably what would be asked of you from this information. Well, we can measure respiratory volumes, and we do that through a test called a spirometry, or through spirometry, using a spirometer, a way to gauge how much air moves into and out of your lungs. And I will tell you that depending on the size of the individual and the size of their lungs, is that your total volume, let's say your total lung capacity, which is the greenish arrow over to the right-hand side, is essentially how much air can be accommodated, in your lungs when they're maximally inflated. What is the total volume? And that's generally dependent on the size of your lung. But when you are at skeletal maturity and you're an adult, or even as a child, you should have a certain amount of volume in there, and that volume can be altered by different pathologies. Whether you have emphysema, it won't necessarily change the total lung capacity, but if you had masses of some kind, in the lung, or maybe tumor, then it's going to change your total lung capacity. All right, so we're going to look at what tidal volume is right through the center there. All right, what inspiratory reserve volume is, what expiratory reserve volume is, and what your residual volume is. So most of the volumes, I would say most people will ask you, maybe by definition, what are the volumes? Not necessarily the capacities, with the exception of maybe total lung capacity. Maybe vital capacity in the online classes. All right, so, when we're talking about an average adult, it's generally somewhere between about, 5,000 to 6,000 milliliters. That's what, of air can be accommodated in the lungs. Right? That's the maximum. But we don't use all that on a regular basis. So right through the center here, where you have the small green wave up and down, represents, it's called the tidal volume. How much air you take in, and exhale, in and exhale. In normal, just resting kind of respiration, little upward swings, lower swings. If I asked you to exhale as much as you can, the next time you exhale, force as much gas out of your lungs, right? That would represent that lower green wave, right, called your expiratory reserve volume. And that's where the green arrow is kind of showing, hey, from the bottom of that dotted line to the next dotted line, that is considered your expiratory reserve volume. And then if I ask you then to go back to normal breathing, and now the next time you take a breath in, you fill, you expand your lungs as much as possible. That takes you up to that highest dotted line. That region from tidal volume to the maximum that you can take in is your inspiratory reserve volume. Okay. And then come back to tidal volume. The volume of air down at the bottom, the residual volume, is the amount of air that stays in your lungs so that your alveoli don't collapse. So there's always a certain amount of air in this system to keep those alveoli from collapsing, so you don't have to try to reinflate them, which you're not going to do effectively, to have gas exchange. So we have tidal volume, the volume of air moved into and out of your lungs during normal breathing, like now at rest. Inspiratory reserve volume is the volume of air that maximally inhaled or can be maximally inhaled above and beyond the tidal volume, forcefully above the tidal volume, and force air in. The expiratory reserve volume is the volume of air that can be maximally exhaled forcefully above and beyond the tidal volume. And residual volume is the volume of air that remains all the time and keeps the lungs from collapsing. So just by definition, in this slide, you can see the different degrees. I mean, the same, it just says the different degrees of effort in breathing move different volumes into and out of the lungs. This measurement is called spirometry. So this image, if this works better for you to kind of see, that's fine. You can see where your little tidal volume is, your inspiratory reserve volume, your expiratory reserve volume, and your residual volume. The capacities are just using those different volumes in different combinations. Your total volume, lung volume, or your total lung capacity, I should say, right over on the right-hand side is that entire region of sky blue, light blue, and then the green on the bottom, the different regions. That's your entire capacity of your lung. And if we just remove the residual volume, right, then we're talking about the vital capacity, right? That's your inspiratory reserve, your tidal volume, and your expiratory reserve. Then if we take different combinations of tidal volume to expiratory reserve, that's your inspiratory capacity. Your functional residual capacity is expiratory reserve volume and residual volume. So if you look at those little brackets there, it's just dividing those volumes differently into groups, which we call capacities. And this does the same thing. It just defines it, gives you some of the average volumes, and that may be helpful for lab. Okay, so that is the end of the respiratory chapter.